All right, everyone. So, welcome back to your CCS exam prep course. It is February 19th, 2025. It's Wednesday, which means that we have not seen each other since last Wednesday because Monday was a holiday. So we are going to pick back up where we left off, which takes us into chapter 7 of the ICD 10 CM tabular list from a coding guideline perspective. As a reminder, our scenarios right now are focused on diagnoses coding. Immediately upon completion of chapter 22 in the tabular list, we will cross over into ICD 10, PCS, and for now, we're just focused on the actual diagnosis code, sequencing, principal diagnoses, secondary diagnoses. We are not getting into, what do you call it? We're not getting into POA indicators right now. We're just focused on diagnoses coding. All right, so I am going to pull up our first chapter that we're working on. And I did mention I have 16 questions that I want to make sure we get through. I would like to do 19, but we will see where we land. All right, so our first question, the patient is under medical management for long-standing bilateral mild stage primary open angle glaucoma, as well as age-related bilateral macular degeneration. 3 days previously, an abnormally high intraocular pressure developed. The patient was treated successfully as an outpatient. Uh-oh, the next day, another pressure spiked, and the patient was admitted for further management. He was treated medically for 2 days, and both the pressure and visual acuity improved sufficiently for discharge. The discharge diagnoses were noted as acute primary open angle glaucoma, macular degeneration, and intraocular pressure. So, one of the things that I want to call out is that we want to make sure that we capture the principal diagnoses. And if you look at how this encounter unfolded, that principal diagnosis is definitely glaucoma based on the UHDDS, Uniform Hospital Discharge Data Set, rules for principal diagnoses. Additionally, the provider listed intraocular pressure as a discharge diagnosis, but there's a guideline that says signs and symptoms that are integral to a condition are not coded separately, and high intraocular pressure is integral to glaucoma and would not be coded separately. The patient is being treated for macular degeneration, and that meets the definition of a secondary diagnosis. And I am going to let you guys go ahead and get started with coding this. And don't forget, please type in the chat when you are um, finished so that I can reveal the answers and we can move on. Also, tonight, when you are coding something and you see the timer, we have like 5 minutes left. If you need to run to the bathroom, just go to the bathroom, come back so that we can not have to take those 10-15 minute breaks. So, like, take a break when you are in between scenarios. All right, so here we go. All right, looks like mostly everyone is done. Took you guys a long time to locate those codes. So we have our code for the glaucoma and the code for the macular degeneration. If you have something different, do a call out in the chat for what you had. If not, we will move on. And I could have typed in wrong H40.1. Let me grab my manual. I definitely could have typed them in wrong. I was looking earlier. So H40.113 is primary open angle glaucoma bilateral. Someone else says they have 13 H401331. So let's look at the difference. So so just so we're clear, H40.113 is primary open angle glaucoma bilateral. And then H40.13 three. Oh, well, first of all, I'm looking at there's a couple of things. I think I missed a character when I was typing because oh no. Only some of them require a seventh character. So H40.113. Let me go back to the index and index this just to make sure I'm not missing anything. So give me a second. Good thing I had my reading glasses nearby. All right, so main term of glaucoma, and the patient has acute primary open angle glaucoma. So open angle, primary sends us to H40.113. And I'm looking in the index to see where there is an option for acute, and I don't see anything. I'm going to just go back to the very beginning. Yeah, I don't see anything that calls out the acute part, but I do see open angle primary H40.11. Let me go back over to the tabular. H40.11. And then, oh, actually, H40.11. And it is bilateral. It's mild stage. So let me just get my pen out. I'll update my notes. So it should be H40.113, and it's mild stage, so 1. H40.1131. H40.1134. H40.1131 in the tabular list in front of H40.113, it tells us to use a 7th character, and the 7th character is for the stage. All right, so everybody all good here? I will I'll update my slide later. All right, let's go to the next one. So wait, I gotta take my reading glasses off to read the screen. The patient, an 18-month-old boy, was admitted with right orbital cellulitis. He was started on antibiotics and seemed to be improving. However, the day after admission, ex-ophthalmos was noticed. Let me just pause for a second. One of the things I challenge you to do as you are coding outside of this Monday, Wednesday situation is that you look up words that you don't know the meaning of, and that you look at what they actually mean, because that can help with understanding of if something is a sign or symptom. That's a guideline, so you better believe that's a concept that they can ask you about on the exam. So I remember 30 years ago, no, 25 years ago. Anyway, I went to my first high school reunion. I can't remember if it was 30. Anyway, back to the story. And it was before the high school reunion, I started planning it with someone else, and I hadn't seen that person since high school. And we were really good friends, but she went away to college. I had a baby, blah, 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 blah. And so as soon as she walked up on me, I noticed her ex-ophthalmos. Her eyes were bulging. And I said, "Oh, do you have Graves' disease, hypothyroidism?" And she was like, "Yeah." That's how I noticed. All right, back to the story, back to the scenario. A non-contrast CT scan of the head showed increasing edema of eye orbit with filling of ethmoid sinus. The medications were changed. A right endoscopic complete ethmoidectomy was performed because the ethmoid sinuses were filled on the right side. The infant improved and was discharged in satisfactory condition. Discharge diagnoses: right orbital abscess, ex-ophthalmos, right orbital edema, acute ethmoidosinusitis. So remember, the principal diagnosis is the condition established after study to be chiefly responsible for the admission of the hospital. And in this particular case, the cellulitis abscess or whatever it was is the reason for this inpatient encounter. The bulging of the eyes is integral to the cellulitis, so it would not be coded separately. The patient has ethmoidal sinusitis. That would be coded because it was specified as acute, so it is happening right now. And that's all I got to say. And I'll put the timer on. All right, I see that you all are done. And so here are the codes. And oh, let me put my glasses back on. Goodness. All right, so cellulitis of the orbit, edema of the orbit, and then acute ethmoidal sinusitis. And we did not code the uh, exophthalmos. All right, any issues with these three codes? I said, as hard as I tried to make sure my typing was correct. All right, let's move on to the next one. So here we have, I think I just added this one today. All right, trying to make sure you had at least 3 per chapter. 72-year-old female with poorly controlled diabetes is admitted for sudden vision loss in her right eye. And ophthalmology is consulted, and an examination reveals a dense vitreous hemorrhage due to proliferative diabetic retinopathy. Given the severity of the hemorrhage and risk of retinal detachment, the patient is scheduled for urgent pars plana vitrectomy. The surgery is successfully performed. During the admission, patient is monitored for complications, discharged with close ophthalmology follow-up and diabetic management optimization. Discharge diagnoses, vitreous hemorrhage, right eye, secondary to proliferative diabetic retinopathy, and then diabetes uncontrolled. All right. I don't really have anything to say about this one. So I will start the timer. All right, it looks like everyone is done. So, we have the hemorrhage, vitreous hemorrhage, the right eye. We have type 2 diabetes with proliferative diabetic retinopathy without macular edema. And then we have diabetes type 2 uncontrolled. Any issues with these? And I need to write down, for some reason, I don't have. I spent about 4 hours getting prepared for this class. And I'm like, I have a handwritten notes, of course. I don't even have H43 on my paper here, but I know what that code is. So, um, all right. So I see no's in the chat. So we are rolling on to the ears. All right. So our first patient, this is an easy one. Bilateral mixed conductive and sensory neural hearing loss, was admitted for a cochlear implant. Bilateral multiple channel implants were inserted through an open approach. The patient was discharged to be followed as an outpatient. And I want to remind you, as soon as we get to chapter 22, we are moving right on to ICD 10 PCS, where you will have scenarios that look like this, but you'll code the diagnoses and the PCS code. Woohoo! All right, go ahead with this one. All right, looks like everybody is done with this one, so I will reveal the code. Just this one code here that includes the um, conductive and sensory neural. This is a code that is near and dear to my heart because my oldest daughter, who is 33, has bilateral sensory neural hearing loss, severe in one ear, less severe in the other. Um, we got her hearing aids probably 30 years ago, and she threw them on the ground. So, needless to say, she does not wear them. All right, any issues with this code? All right, we're going to move right along to the next question. Patient has a history of chronic suppurative otitis media in the right ear with recurrent infections and progressive hearing loss. He presented with persistent purulent ear damage, ear drainage, tinnitus, and decreased hearing. Examination revealed a large tympanic membrane perforation, and culture identified Pseudomonas aeruginosa. He was treated with topical and oral antibiotics. The infection improved or resolved. Due to persistent perforation and hearing loss, a tympanoplasty was planned. Discharge diagnoses: chronic suppurative otitis media, right ear, tympanic membrane perforation, right ear, conductive hearing loss, unilateral right ear, and Pseudomonas aeruginosa ear infection. And I don't have any guidelines to report on this one. All right, looks like most of you are done. So I am going to reset the timer. All right, so for this scenario, uh, here are the four codes. And that H66 3X1, I looked that one up earlier today, I remember. All right, and after you review, anybody questions, go back to the scenario. All right, so it should be H9011 and not H9041. Anything else with this one? So change H9041 to H9011 because it is conductive and not sensory neural. All right, let's go on to the next one. And let me just 1 second. So that we did ears. No, we did eyes. Now we're on ears. Okay. All right. The last scenario for chapter 8. 58-year-old male with a history of chronic otitis media, type 2 diabetes, admitted for worsening ear pain, hearing loss, fever over the last few days. Examination reveals severe swelling, purulent damage from the right ear, tenderness over the mastoid process. CT scan confirms a diagnosis of acute mastoiditis. with abscess formation given the severity of the infection and the risk of intracranial spread. Patient started on IV antibiotics, undergoes urgent mastoidectomy during hospitalization, postoperatively monitored for improvement. Diabetes is managed to aid recovery, discharged with ENT follow-up, antibiotic therapy. Diagnoses: acute mastoiditis with abscess, right ear, chronic otitis media, right ear, type 2 diabetes, uncontrolled. Well, we already know what that last code is. All right, let me hit the timer. Right. Looks like everyone is done. So let's get going here. Hopefully I typed these in correctly. Let me know if there are any issues with any of them. Um, so at the bottom of the documentation, the doctor says that it's type 2 diabetes mellitus uncontrolled, which is why we are using that E1165. Now, real world, of course, you would have the entire note instead of a little paragraph, but at the bottom here, since it says type 2 uncontrolled, we can use that. Anything else here? And again, if you have a question, go ahead and type in the chat. Oh, we are doing good on time. I am excited. Except we definitely need to take a little break because circulatory system, I have 5 cases instead of 3. So any more questions before we take a break? For otitis media, it says that there was purulent drainage. So let me go back. Um, Examination reveals severe swelling, purulent damage from the right ear. So your thought is that final otitis media code should have the pus in it. So I agree. Let me look up what that number would be. So I'm thinking that should be something like 866.3 something. All right, 866.3x1. Why do I feel like we coded that already? Okay, 1 second. Let me get my notes here. 866 point. Oh, and I have that on my paper. I must have not have retyped it. And then H70.001 versus 011. So let me see what that is. I'm gonna have to double check my data entry. H70.11 is chronic mastoiditis. H70.001 is acute, and our mastitis was acute, so that should be, and ours was right ear, so H70.001. All right, I gotta check my data entry next time. All right, anything else with this one? Okay, so if you have something else, please go ahead and put it in the chat. So far we have H66.3x1 for the suppurative otitis media. We have H70.001 for the acute mastoiditis. And then at the end of the note, the statement says type 2 diabetes uncontrolled. Uh-oh, abscess formulation. Okay, let me go back. All right, so I'm in the tabular and category H70.0 says acute mastoiditis, abscess of mastoid. And let me go back to the scenario. So it was acute. H70011 is a subperiosteo. So let's see what the scenario says. Did it say subperiosteo? Acute mastitis with abscess right ear. Let me go back to the top of the scenario. So worsening ear pain, hearing loss, fever, tenderness over the mastoid process. Anybody else would want to use subperiosteo abscess? I don't know if I see that in the documentation. I see the abscess, and that's included in the H70.0 family. Anyone else with thoughts? So it looks like the consensus is H70.001, acute mastitis without complication, right ear, and that part about that abscess with the abscess formation. That's kind of one that I feel like I may need to query to confirm where I would land. Anyone else with thoughts? Code family H70 is acute, so they're all acute. H70 00, H70 01, H70 09. Yeah, so I would want to query because it says tenderness over the mastoid process. So that could be it. But I maybe want to query. Now some would say it's over the mastoid process, so that's a bone, so they would go with periosteo, but sub means below or under, and it says tenderness over the mastoid process. So I kind of feel like with that one I would need to query to get the one. Okay, so let's take a 10-minute break. All right. Before we go on to chapter 9, I did some additional research because that's just my thing on a subperiosteal abscess. So, number one, these are collections of pus in the subperiosteal space located between the periosteum and the cortex, with the vortex of both structures at the perichondrial joint. That was one definition I got. That was from a radiology association. And then I read some research, which was boring. Another definition: subperiosteal abscess is a collection of pus that forms between the periorbital and orbital bones. It could be due to a number of infections, including sinusitis, ethmoiditis, or odontogenic infections. So before I would go with the subperio abscess, I would query. On the CCS exam, um, it won't be where there's a bunch of gray. And so we will move forward. All right. Okay, let me take my glasses off. Whew, chapter 9. I'm so excited. Chapter 9. Start off easy. The patient was admitted and treated for the following diagnoses: stage 5 CKD with acute on chronic systolic congestive heart failure due to hypertension. And remember, ICD 10 uses a combination code for hypertensive heart and CKD. So just remember that this patient has hypertension, heart failure, and CKD. I'm going to start the timer. All right, looks like most of you all are finished. So here are the codes. And I'm assuming that this is something that you guys code at work, so you kind of knew the numbers off the top of your head. Any issues with these three codes? Yeah, when so let me just tell you, I said, now I was debating, should I go to the bathroom on this one or should I wait? Soon as I got up out my seat, it was like, boonk. I said, oh no, they know these codes by heart. All right, on to the next one. So the patient was admitted to the hospital with an acute STEMI of the anterior wall involving the left anterior descending coronary artery. Day 4 of admission, the patient suffered a second STEMI of the inferior wall. The patient's paroxysmal atrial fibrillation and hypertension were also treated during the encounter. So before we actually code this scenario, who could tell me the guidelines, the guideline that apply? So of course it's chapter 9, E, chapter 9E. I'm pretty sure it's a E. That sounds about right. D or E. And what else did I want to say? So when you have that guideline, go ahead and throw it in the chat. Yeah, and I wasn't even going to say what number it was. Um, E E1 or E4. So I guess the thing here, look at my font. So as you can see, I do my own typing for the most part. I do have my virtual assistant do some typing, but we definitely messed up the formatting on this one. But so the patient was admitted with a STEMI. And then 4 days later, they suffered a second STEMI. And uh, there are some guidelines regarding the use of codes in family I-21 and I-22 in terms of which one would go first, because now you have the first STEMI and then you have a subsequent STEMI. So anybody else with guideline thoughts? Nobody else with guideline thoughts? I'm gonna go in my physical code manual. There are guidelines right in front of the tabular list. So let's see. Definitely E for myocardial infarction because D is sequelas. And it talks about the codes identify the site as anterior lateral wall or true posterior wall. And it tells you what the codes are used for. I-21, 0, 2, 3, 4. Okay. So I think that's a good guideline. But also E4 talks about subsequent myocardial infarction. A code for I-22 subsequent ST is to be used when a patient who has suffered a type 1 or unspecified AMI has a new AMI within the 4-week time frame. A code from category I-22 must be used in conjunction with the code from I-21, and the sequencing of those codes depends on the circumstances of the encounter. So, this patient came in the hospital with this acute MI, and while they were there, they had another one. So, the initial MI is going to be the principal. So, I'm going to stop talking because by now you guys, you should have the codes. So, I'm going to stop talking. All right. So for this case, you need a code for the initial MI, a code for the subsequent MI, a code for the um, I-48 proximal atrial fibrillation, and then a code for hypertension. Any issues with this one? All right, we will keep going. And while I'm thinking about this, I did want to tell you a week from today, you will have an exam. Bum, bum, ba-dum, bum, bum, bum. Question number 3. The patient was admitted to the hospital with an acute STEMI of the inferior wall. The patient had a previous admission 3 weeks prior um, for treatment of an acute STEMI of the anterior wall. So you have to ask yourself, what is the reason for this admission? So they had a STEMI 3 weeks ago, and now they're back with another one. This should not take you that long to code either. Alrighty. This one was actually very easy. Two codes with the subsequent first, followed by that other one from 3 weeks ago. Any issues with these two codes? All right. Um, Question 4. 67-year-old gentleman was admitted with unstable angina. Patient has a history of two vessel coronary artery bypass 18 months ago. Recent cath shows evidence of the disease, but both of the bypass grafts are patent. Patent means that they are open. The patient also, and that makes a difference in terms of which coronary artery disease code you select, because when they've had a cabbage, the question is, do we have fat plaque in the bypass grafts, or is it in the one they was born with? So if it's not in the one they were born with, if it's not in the bypass graft, it's in the one they were born with. The patient also suffered a cerebral vascular infarction 4 years ago, resulting in right-sided dominant hemiparesis. And I'll start the timer. All right, looks like mostly everybody is done. I started the timer late. So the codes for this one, I-25-110. This is arteriosclerotic heart disease with angina pectoris. Um, then the residuals from the hemiplegia from the stroke, and then Z95.1 shows that they have a graph. Any questions on these codes? And I'm gonna go with silence as a no and move on to the next one. The last one for uh, cardiovascular. So, an 80-year-old female was seen in her physician's office for follow-up visit. 9 months ago, she had a cerebral infarction for which she was admitted to the hospital at the time. As a consequence of the infarction, she has right-sided hemiparesis and dysphagia, and that's dysphagia with a SIA and not a GIA. She had been receiving outpatient PT, making good progress. Um, she is also being treated for hypertension, medications renewed, and she'll be seen in the office for 6 months. When I look at this scenario, uh, I'm like, they admitted this patient to the hospital. I don't know if the insurance company would approve this. But anyway, I'm gonna set the timer for this one. All right, and the codes are here. So you have a sequela of the right-sided hemiparesis, and then there's a guideline that states if the affected side is not documented, but specified as dominant or non-dominant, if the right side is affected, the default is dominant. Questions? Oh, and then the dysphagia code and the hypertension. Questions on this one? Yeah, either one could be principal. And of course, the circumstances of the admission would verify which one. Personally, I don't even think this one is an inpatient stay, but I don't think it would qualify. But nonetheless, all right, on to the respiratory system. So, in case you're wondering, um, yeah, if they were rehab but not like inpatient hospital. Um, so for your exam next week, it will cover chapters tabular lists 1 through 11. It will be 3 hours in duration and it will be in the system. And I will review the system with you on Monday just to make sure you're all good with using it. All right, question number 1. Patient was admitted with a gradual increase in shortness of breath, which was unresponsive to home neb treatments. In the ER, patient received more respiratory treatments but failed to improve. The patient subsequently was admitted to the hospital with a theophylline level of 5.9. Chest x-ray showed no evidence of active infiltrates. Patient was bolused. I think that's spelled wrong. Bolus, not bloused, bolus with IV steroids and started on frequent respiratory therapy treatments. IV amniofylline boluses and drip were also administered. The patient gradually improved. The IV amniofylline was changed to PO by mouth and discharge diagnoses severe persistent asthma with status asthmaticus and exacerbation of the COPD. Should not take that long to code these two. I'm going to start the timer. Should only need 5 minutes for this. All right, so that was a good 5 minutes. And so here are the codes. So we have the status asthmaticus and the COPD exacerbation J44.1. Any questions on this one? All right, on to the next one. So a patient was admitted to the hospital in acute respiratory failure with hypoxia. He has emphysema due to cigarette smoking for over 50 years. Sputum culture shows Streptococcus A pneumonia. Patient was intubated in the ER, started on a vent, was ultimately extubated and able to breathe on his own, was started on medication to treat his dependence on nicotine. Acute respiratory failure with hypoxia, pneumonia due to Streptococcus A, and emphysema. Clock starts now. Okay, I accidentally clicked the button and I see that a couple of you are done. So I'll start to talk about the codes. Okay, wait a minute. What did I do? So we did that one already, and now we're on this one. Okay. So we have the respiratory failure with hypoxia as the principal diagnoses. And although the patient had respiratory failure and pneumonia on admission, if you look at the treatment, most of it was directed towards the respiratory failure, which is why we put the respiratory failure first. The patient was dependent on some nicotine. They had the emphysema. They also had pneumonia. And the pneumonia had, it was pneumonia due to Streptococcus A, followed by the emphysema. Questions on this one? All right, so we have about 10 minutes left. So on Monday, we will pick up with question number 3 and go to 3 through 5, and then we'll head on over to um, J is respiratory, so L is the skin. So as usual, I will need to take attendance and